So good evening. I hope you're well. I'm Gautam, a third-year medical student. The focus of this evening's lecture is nerve conduction, autonomic transmission / synapses. There will be some MCQs, and so I'll pause for you to maybe just jot down some answers to that. And obviously, since this is a recorded lecture, we'll then go through the correct answers afterwards. So here's a slide which details the syllabus points that this revision lecture aims to address. One thing I would highly recommend is, as you comb through the content, think of possible essay questions for Part B and also potential focal points for the MCQs in Part A. Additionally, try and think about how the disruption of action potentials and resting membrane potentials potentially manifest in pathology. For Part A MCQs, it might be helpful to incorporate some of the questions into Quizlet flashcards, Anki decks, or whatever method or platform works for you. So let's start with the resting membrane potential. Both in terms of logical progression and also in terms of creating neat essay plans for this topic, it's important to realize that there has been a refinement of the mechanistic model of how the resting membrane potential is established and maintained over the course of history. So what is the resting membrane potential to begin with? It is the difference in voltage between the intracellular component of a neuron or myocyte compared to the extracellular environment. How can we measure the resting membrane potential? One way is using a cathode ray oscilloscope. A glass microelectrode is inserted inside the nerve or muscle cell, and the other microelectrode is placed on the cell surface. The charges are localized at the membrane due to the attraction between the positive and negative ions, and the rest of the cell is neutral. The voltage difference across the membrane is due to the uneven distribution of these ions, so that the inside of the cell is more negative, which gives a resting membrane potential of around -65 millivolts, but it obviously varies between different cells. The diffusion of these ions is really dependent on the electrochemical gradients, as well as the permeability of the plasma membranes to individual ions. The movement of only a small proportion of these ions will cause a significant difference in the membrane potential. And this is important to bear in mind, not only for resting membrane potentials, but also action potentials, which are covered later. So resting membrane potential related calculations are a topic that examiners like to visit for MCQs. A prerequisite for these questions, alongside answering the renal physiology questions on the course, is knowing the physiological values for critical ions. A complete list of the ions that you need to know is in the syllabus handbook, but here are some important ones to remember. So next, we shall consider the role of potassium and sodium diffusion in generating the membrane potential. As ions are charged particles, their diffusion across the membrane through ion channels will depend on both the electrical and chemical gradients. Consistent with Bernstein's membrane theory at the beginning of which was proposed at the beginning of the 20th century, the main contributor to the resting membrane potential is the passive efflux of potassium ions, and chemical gradients are maintained by a pump called the sodium-potassium activated adenosine triphosphatase pump, or the sodium-potassium ATPase alternatively. The diffusion down the chemical gradient causes a separation of charge and the establishment of a potential difference, where obviously the intracellular environment is more negative compared to the extracellular environment as covered in the previous slide. The potential difference acts as an electrical driving force, with the efflux of potassium down its chemical gradient being opposed by the influx of potassium down its electrical gradient. And eventually an equilibrium is reached where there is no electrochemical gradient, and therefore no further net movement of potassium ions occurs through the potassium channels. The voltage at which this equilibrium occurs is called the potassium ion equilibrium potential, EK as the nomenclature. The net influx of sodium is counterbalanced by the potassium efflux because the membrane is more permeable to potassium. This leads to a net flow of positive charge out of the cell, so the inside of the cell is negative compared to the outside. Note that the permeability can be calculated by rearranging a fixed law, but this isn't on the left-hand side of the syllabus, so it's just something to observe, perhaps include in Part B essay if required. So next, this item is on the right side of the syllabus, but for each ion, there is a voltage difference across the membrane, which would create an electrical potential that would balance the ion's concentration gradient to make both influx and efflux equal. The membrane potential is denoted EM, and the equilibrium potential is EX, where X is the chemical symbol. For instance, the equilibrium potential of sodium is ENA. Here are some equilibrium potential values that are important to the establishment of the resting membrane potential, and this is important in considering the double Donon distribution. Specifically, the double Donon distribution was an early model of ionic and osmotic equilibrium across the cell membrane, and in this model there are impermeant ions such as proteins inside the impermeant anions such as proteins inside the cells, and impermeant cations such as potassium and sodium outside the cell. The diffusion of potassium and chloride down the electrochemical gradients then sets up the ultimate membrane potential, reaching an equilibrium at around minus 87 millivolts. So what are the key limitations of this model? The key limitation is that it assumes that membranes are in fact only permeable to sodium. The next equation we should consider is the Nervest equation, and this equation can be used to calculate the equilibrium potential for a particular ion, that is the voltage difference that would be needed to create an electrical gradient equal and opposite to the chemical gradient. It's given by the following formula. We've used potassium as an example here, where E equals RT over ZF ln extracellular potassium over intracellular potassium, where R is the gas constant, T is the temperature in kelvins, F is the Faraday's constant, Z is the valence of the ion, and extracellular potassium concentration and internal concentration are given as the quotient of the ln. So what are the assumptions made by this equation, the Nervest equation? Please do write down your answers as we pause for a short period for this. So the primary assumption is that it assumes that the membrane is 100% permeable to the ion in question. So it only calculates what the membrane potential would be if that particular ion were the only ion involved in establishing it, which is obviously not the case in a physiological context. The closer the actual membrane potential is to the Nernstian value of a particular ion, the greater the value, the role of that ion in establishing the membrane potential, and the higher the membrane permeability to that specific ion. The equilibrium potential of potassium ions in spinal neurons of a mammal is minus 90 millivolts, which is relatively close to the resting membrane potential of minus 70 millivolts. So from this, we can conclude that potassium plays the predominant role, but not the only role in establishing resting membrane potential. An expected question after the last slide might be, how can we test the assumption that the membrane is only permeable to potassium? This was done by Hodgkin and Horowitz in 1959. The Nervest equation assumes that the membrane potential is only permeable to potassium, and this was tested in 1959 through the experimentation on frog muscle fibers. Hodgkin and Horowitz measured the membrane potential of the cell when the external potassium ion concentration was varied, and compared it with the expected results calculated from the Nervest equation. At high potassium concentrations, that is extracellularly, the Nervest equation provided a good model for the results, showing that potassium ion concentration indeed has the largest effect. However, when the potassium concentration was less than 10 millimolar, the experimental values deviated significantly from the expected values. From this, one can conclude that the membrane potential is not entirely impermeable to other ions, but their values are minimal and only noticeable when extracellular potassium concentration becomes very low, so as to prevent much of the diffusion of potassium to because of the greatly reduced chemical gradients. It's therefore clear that we need a more refined model that incorporates the varying membrane permeabilities of each of the ions involved. So this brings us to our next equation, which is also important to include in a Part B essay, the constant field equation. This shows that the expected membrane potential involves a number of ions that are diffusing that can be calculated using the Goldman-Hodgkin-Katz voltage equation, which not only takes into account the concentration of ions, but also the permeability of each ion through the membrane. It is given by E equals minus RTF ln, and then the permeability of each ion times the concentration extracellularly on the numerator, and you summate all of the ions involved, sodium, potassium, and chloride. And for the denominator, you do the same, but obviously for the intracellular, but also it's flipped for chloride because of the different direction of flux. So R is the gas constant, T is temperature in Kelvin, F is the Faraday's constant. So quite similar to the previous equations we've seen with the Nervest equation, but the main difference is the insertion of permeability. So the resting membrane potential is an aggregate of the equilibrium potentials of all the separate ions, and the plus 58 millivolts equilibrium potential of sodium makes the resting membrane potential less negative than the minus 90 millivolts predicted by the potassium ion efflux alone from the Nervest equation. Have a think now about how an increase in extracellular potassium, extracellular sodium, or extracellular chloride would impact the membrane potential. I'll just pause for a little bit for you to potentially just write those down. Okay, so let's go through them individually. Increasing the extracellular potassium would make the membrane potential more positive because it would decrease the concentration gradient for potassium efflux. So more positive charge would remain intracellularly. In terms of increasing the extracellular sodium, this would also make the membrane potential more positive because it would increase the concentration gradient for for sodium influx. So more potassium, so more positive charge would then enter the cell. And finally, increasing the extracellular chloride would make the membrane potential more negative because it would increase the concentration gradient for chloride influx. So more negative charge would enter the cell. And so therefore, changes in the extracellular concentration of any of the salient ions can dramatically impact the resting membrane potential. So now we move on to the role of sodium-potassium ATPase, which is a key point in the syllabus. The sodium-potassium ATPase transports sodium out of the cell and potassium into the cell, maintaining a concentration gradient for diffusion to occur as above, as well as the indirect contribution to the chemical gradient maintenance. The electrogenic nature of the sodium-potassium ATPase pump has a small direct effect on the resting membrane potential, but this is not the largest effect by any means, and it's still really the membrane equilibrium potentials of the individual ions summated that really contributes to the resting membrane potential. However, there is a bit of nice experimental evidence to include potentially in an essay for this. In 1957, Post and Jolly cooled erythrocytes to a temperature at which the sodium-potassium ATPase could no longer function and only diffusion could occur. When the temperature was increased slowly, the sodium-potassium ion concentration change in a specific period showed that for every 3 sodium ions actively transported from the cell, only 2 potassium ions are moved. This gives a net movement of charge out of the cell, although the effect is small, leading to a hyperpolarization of between 0.5 and 10 millivolts in all cells, so a relatively small effect size. Given all this, how can we apply this to a clinically relevant context? Specifically, have a think about hyperkalemia and hyponatremia, and also hypokalemia, sorry. As a consequence of the central role of potassium in resting membrane potential, the significant change caused by the movement of small amounts or changes in the extracellular concentration of potassium, specifically in the ECF, the extracellular fluid, can have a dramatic impact on physiology and health. An increase in potassium extracellularly, known as hyperkalemia, will reduce the concentration gradient for it to be expelled from the cell during efflux, and therefore there will be more positively charged cations inside the cell, and therefore depolarization will occur because of this hyperkalemia. Hypokalemia is the opposite, as the name suggests, where extracellular potassium is decreased and the hyperpolarization follows from this. It can be caused by a loss of renal function and can cause hyperkalemic periodic paralysis, which involves weakening of the muscles and periods of paralysis related to the generation of action potentials. It's worth noting that both conditions can cause cardiac arrhythmias. So here's an example of some questions that may come up in Part A. They're yes or no unless indicated, and the options have been embedded inside the questions. So I'll pause briefly so you can write down your answers, and then we can go through the answers. So is the resting membrane potential of an excitable cell many times more or less permeable to sodium compared to potassium? Less. Is the sodium-potassium ATPase pump necessary to restore the membrane potential to its resting value at the end of action potential? No, because as mentioned in the previous slide, the hyperpolarization is relatively minor, although it does have an effect size. It's not necessary, as shown by the experiments by Jolly. Increasing the extracellular potassium concentration, would it hyperpolarize or depolarize the resting membrane of an excitable cell? It depolarizes it, as covered with hyperkalemia. Will the resting membrane potential of this excitable cell be the same as the potassium equilibrium potential? No, because firstly, you've changed the potassium concentration and also the involvement of the other ions. So the next topic to consider in this lecture are action potentials. I think throughout this topic, it really helps to consider how the factors influencing action potentials might manifest in pathologies, particularly those involving demyelination. Action potentials are rapid 1 to 2 millisecond transient changes in the membrane potential that occur in excitable cells, such as neurons, muscle cells, and endocrine cells. It is a rapid depolarization of the membrane, usually up to around plus 40 millivolts, as shown on the diagram. The membrane potential becomes much more positive at that upstraight phase. It occurs when the membrane is depolarized beyond a threshold level, generally about plus 15 millivolts, above the resting membrane potential, by changes in the distribution of ions. It is a all or nothing response, and if the threshold is not reached, there will be no effect, and similarly there won't be a supra physiological effect for a greater initial depolarization. And after the depolarization, repolarization and often hyperpolarization occurs. There is a rapid increase in sodium conductance due to the opening of voltage-gated sodium channels. The increase in sodium conductance leads to an influx of sodium down its electrochemical gradient, and this increases the number of cations in the cell and leading to a more positive charge inside the cell, leading to depolarization. And this depolarization of the membrane also opens voltage-gated potassium channels, but the potassium channel conductance increases much more slowly than sodium channels because of delayed rectifiers. The efflux of potassium gradually increases, and the influx of sodium simultaneously decreases due to the spontaneous inactivation of sodium channels discussed earlier. And this overall leads to a net efflux of positive charge, causing repolarization. And the increased potassium conductance continues for slightly longer than necessary for repolarization, causing the hyperpolarization stage shown in the diagram. Now, in terms of part B, there is a lot of nice experimental evidence for this mechanism. So the action potential mechanism was largely elucidated by the work of Hodgkin and Huxley in 1952 through voltage clamp experiments on the squid giant axon. Voltage clamping enables the direct measurement of ionic flux whilst holding membrane potential at a particular value. Their analyses showed that the sodium and potassium permeability of the membrane of an axon is gated by the change in membrane potential, and that the two currents is separated easily when one of the channels is blocked by a pharmacological agent. And this was subsequently done by Sigworth and Neo with patch clamping on cultured rat muscle cells. Patch clamping is a technique that involves the excision of a small section of plasma membrane containing one or more channels, which can be examined in real time, offering an advantage over the voltage clamp method shown above used by Hodgkin and Huxley. The potassium channels were blocked by the drug tetraethyl ammonium TEA, which prevented the repolarization, suggesting that repolarization is due to the outward flow of potassium ions. And similarly, when tetrodotoxin is used to block sodium channels, the action potential is inhibited. The size of the action potential generated is constant and independent of the size of the initial stimulus once the threshold value is reached, and any further stimulus has no effect, and this is known as the all or nothing law. This was actually developed by Adrian et al. In the 1920s through the direct observation of the consistency of action potential size in motor and sensory neurons. One consequence of this phenomenon is the intensity of the stimulus cannot be communicated by a single action potential, and therefore information about its intensity must be gleaned from the frequency of action potentials, although there is an upper limit due to the refractory period, both absolute and relative. And so this has interesting implications for computation that you might want to consider. In terms of channel states, it's useful to think of the state of the ion channels during action potential. The channels are open and closed according to the membrane potential as found by Huxley. The sodium channel can exist in three different states: closed, open, and inactivated. Depolarization of the membrane opens the channels, leading to influx, and is then spontaneously inactivated. This spontaneous inactivation stops the suddenly increase in sodium influx and allows the repolarization to occur. The delay that occurs when sodium channels switch from inactivation to closure also corresponds to the refractory period. Repolarization closes the channels that are either open or inactivated. But on the other hand, it's worth noting that the potassium channel only exists in two states, closed and open. Therefore, the opening of potassium channels occurs more slowly than the opening of sodium channels. So there is a net free efflux of positive charge to cause depolarization. These potassium channels also close slowly after repolarization is achieved, leading to the hyperpolarization seen in the action potential plot. Now moving on to the major passive electrical constants in action potential conduction. We'll start with the length constant. The distance that an action potential can be conducted along an axon and the velocity of this conduction are dependent on the two major parameters of length constants and time constants. And it's important to consider both their quantitative and qualitative significance. The length constant is qualitatively the distance that can be traveled along the axon for the voltage to decrease to 1/e of the original value. And this ultimately indicates the length of the neuron that can be depolarized to threshold value by the initial impulse. A greater length constant thus corresponds to a greater length of the axon that can be depolarized, meaning that the action potential can travel further. The length constant is dependent on the internal resistance and membrane resistance, denoted by Ri and Rm respectively, and the quantitative equation that defines the length constant is length constant lambda equals the square root of the Rm over Ri, so in membrane resistance over the internal resistance. And from this, the actual explanation is that if the membrane resistance is high, the leakage of charge through the membrane will be reduced, and therefore the length constant will be greater. However, similarly, if the internal resistance is low, the charge will diffuse more easily through the axoplasm, and therefore the length constant will be greater. Now, onto the time constant. The time constant is the time taken for the same voltage decrement to occur. It indicates how long it would take for sufficient charge to build up on the membrane, which is ultimately acting as a capacitor. So it's a measure of capacitance over time for the threshold value to be reached and the action potential to be triggered. A smaller time constant leads to a more rapid depolarization of the axon, and the time constant is dependent on the capacitance of the membrane, Cm, which is a measure of how much charge must move across the membrane to generate a change in membrane potential, the membrane resistance, Rm, and therefore the time constant equals Rm times Cm, so the capacitance times the membrane resistance. The lower the membrane resistance and the lower the capacitance, the easier it is for the action potential to be regenerated, and so the faster it will travel along the neuron. It is important to remember that the internal resistance is inversely proportional to the cross-sectional area of the axon. This will be important when we consider the different types of axons, or the different types of nerve fibers rather, and the membrane resistance is also inversely proportional to the circumference of the axon. And so although these interact to ultimately lead to a larger radius leading to a larger length constant, which has implications for the conduction properties of different neurons. So electrical chemical diffusion is often insufficient. So what is the solution? This brings us on to this slide of myelination and saltatory conduction. Myelination is a method of dramatically increasing conduction velocity by up to 50 times. Myelinated axons have Schwann cells wrapped around them many times, which essentially produce a system of multiple membranes in series around the axon. And there are unmyelinated regions between these, known as nodes of Ranvier, where the action potential is refired to prevent it from being distorted, and also increasing saltatory conduction. Nodes allow for a very rapid initiation of action potentials, namely because they have a high density of voltage-gated sodium channels, and they therefore establish these local circuit currents with the action potential passing very rapidly by electrochemical diffusion along the myelinated internodes, and then depolarizing the membrane at the next node to rapidly refire an action potential. This essentially causes the action potential to jump between the nodes, resulting in a very high conduction velocity, and hence the name saltatory conduction. But this poses a significant problem. How is orthodromic conductance, that is, the conductance of action potentials in one direction, maintained? Action potentials, as we know, can be only propagated in one direction, although later you will come across dendritic backpropagation as part of potentially your FHS options. But how is this overcome? So although the local circuit currents spread in both directions from the region of depolarized membranes, i.e. the nodes of Ranvier, the sodium channels behind the preceding action potential are inactive, so ultimately no retrograde depolarization can occur. So what effect does myelination have on the passive electrical constants of time and length constants? It's really important to tie these concepts together. Myelination increases the membrane resistance by preventing leakage of charge from the axoplasm, which therefore dramatically increases the length constant. However, on the other hand, increased membrane resistance does increase the time constant, as charge separation cannot build up so rapidly on the membrane. There's decrease in membrane capacitance because myelination produces the equivalent of sort of capacitors in series if you're going to use the circuit model. And this means that less charge needs to move to generate the membrane potential required for threshold, or the progression of an action potential in this case. The change in the capacitance is more significant than the change in membrane resistance. So overall, the time constant is reduced, meaning more rapid depolarization occurs. And the effect of myelination is therefore to increase the length of the membrane that can be depolarized to threshold level by an action potential, and the speed with which this depolarization occurs. And subsequently, the refiring of the action potential is expedited, and consequently, the conduction velocity increases dramatically to approximately 50 meters per second. Now, here's a table with the conduction velocities of several types of nerve fibers. The examiners like to test this in MCQs, but memorizing the exact values is sort of secondary to understanding the relationship of fiber radius and conduction velocity, and you can normally deduce which fiber type they are asking in a question by looking at the options. So that's what we'll do now. So looking at the following, I'm just going to give you an example of the kind of Part A questions that might come up for the nerve fiber classifications, and I'll pause briefly so you can write down your answers, and then we can go through your answers. So looking at the following values, 5 millimeters per second, 5 centimeters per second, 5 meters per second, 50 meters per second, and also 5,000 meters per second, what is the approximate conduction velocity of an unmyelinated nerve of at least 5 microns in diameter? 5 milliseconds if you go back to the previous slide because of the reduced radius. Myelinated nerve at least 5 microns in diameter is obviously much faster because of the myelination, so it's 50 milliseconds. And if the action potential lasts 2 milliseconds, calculate the distance along the myelinated axon that the action potential occupies. So this is just a simple speed distance time equation rearrangement. Choose 2 factors that would increase the velocity of the conduction of an action potential in nerve fibers. So increase in membrane resistance in terms of length constant, increasing it and reducing the time constant, and also increasing the temperature, which also increases the rate of electrochemical diffusion of the ions. So therefore would increase the rate of conduction velocity. So now moving on to drugs that influence the action potentials. So tetrodotoxin is a sodium channel blocker. When action potentials are studied in the presence of tetrodotoxin, as seen in previous experiments explained, the upward stroke is abolished. So essentially the action potential part is abolished. And actually tetrodotoxin is found naturally in the ovaries of the pufferfish, a delicacy in Japan. Another sodium channel blocker is saxitoxin. Other sodium channel blockers are local anesthetics, anti-epileptic drugs, and antidysrhythmic drugs to essentially reduce the level of nervous excitation. Tetraethyl ammonium TEA is a potassium channel blocker, and it abolishes the downward stroke of the action potential, so the repolarization, as expected, given the role of potassium in repolarization and ultimately hyperpolarization. So here's an example of the kind of Part A questions that could come up for this section of this topic. I'll pause briefly so you can write down your answers, and then we can go through the answers. So firstly, name the membrane channel responsible for the inward current during the depolarizing phase of the action potential in nerve fibers. So as mentioned in this previous slide, this is the upstroke of the action potential, so it's the voltage-gated sodium channels. Name one drug that blocks these channels. Tetrodotoxin is one of them. Obviously, you could also have chosen, if they were options, local anesthetics or anti-epileptics. Name which membrane channels are responsible for the repolarizing phase of the action potential in nerve fibers. This is the delayed rectifier potassium channels, as mentioned previously. Name a drug that blocks these channels. It's tetraethyl ammonium. What accounts for the absolute refractory period following an action potential? This is voltage-gated sodium channels, specifically because of their inactivation rather than relative refractory period. Now, this slide actually hits a nerve, particularly with me, because I actually recently sustained a nerve injury in my arm, which underwent surgery for recently and also previously in the other arm. So what is Valerian degeneration? It's a sequence of processes that occurs if an axon is transected. The cell body tries to repair the axon by synthesizing new proteins. It often becomes sort of swollen and rounded with the products of protein synthesis around the axon. And the axon distal to the point of severance dies or degenerates, resulting in the denervation of the effector. This is known as Valerian degeneration. In myelinated neurons, the myelin sheaths will also be phagocytosed. The original Schwann cells remain, however, and if the axon that degenerates is the only innervation for a particular effector, that effector will often die after the degeneration of the neuron. This occurs in skeletal muscle, with cells atrophying if their nervous supply is lost. In terms of essays, there's a broad swathe of things you could potentially include for clinical relevance bonus points in your essays, like trauma, carpal tunnel syndrome, cubital tunnel syndrome, brachial plexus injuries, Erb's palsies, mononeuropathies, and polyneuropathies. I'm not going to cover exactly what any of these are, but feel free to look them up after the lecture and add them to your essays. In addition, you could try and get more bonus points by weaving in some knowledge of clinical signs like the sign of benediction, ulnar claws, hyperextension of the metacarpopharyngeal joints, which also constitutes the ulnar claw. Now, moving on to sort of systemic pathologies. In the previous slide, we considered damage at the level of a single nerve or select nerves owing to trauma, etc. But it's important to consider more systemic disorders as well, affecting nerves. So in multiple sclerosis and Guillain-Barré syndrome, myelin is progressively lost as a result of autoimmune attack. The length constant therefore becomes gradually shorter, so the action potential loses magnitude and essentially becomes distorted as it passes along the axon. Eventually, the action potential may lose so much amplitude during the upstroke that the threshold value is not reached at the next node after passing across the local node, the internode via the local circuits, and so, therefore propagation will simply not occur. This leads to the progressive loss of motor control and is eventually fatal. Motor neuron disease is caused by the atrophy of axons of motor neurons, and the symptoms are weakness, wasting of muscles, increasing loss of mobility in the limbs, difficulties of speech, swallowing and breathing. So now onto the autonomic transmission in synapses. I focused more on this lecture on resting membrane potentials and action potentials in this lecture rather than the autonomic synapses, largely because the MCQs tend to focus that way, and apart from the comparison questions, this is less covered in exams generally. But there are some key facts for autonomic transmission which may be useful to go for revision. So it's worth noting that the synapses on cardiac and smooth muscle are en passant junctions occurring at varicosities, which are bulbous swellings along the length of an axon, where the neurotransmitter is released ultimately to the effector organs of the heart and the smooth muscle, or perhaps for gut motility. This allows an increase in the number of targets that a single axonal branch can influence, and leads to a wider distribution of autonomic output. Think about this in contrast to motor units in skeletal muscles, and always try and link the structural and differences to their functional importance when comparing these systems. This is usually stressed in the examiner's reports because they like to see candidates making the link between structure and function. I think for essays where the question is asking you to compare the somatic and autonomic nervous system, it might be useful to include a brief table just after the introduction, like the one on the slide, to demonstrate early on to the examiner that you are sort of structuring your response logically. So a difference between somatic and autonomic effectors are skeletal muscles versus cardiac muscles, smooth muscles, blood vessels, and airways. The effect is excitation with somatic nervous system inputs versus excitation and inhibition, and this kind of couples to the innervation being single versus dual. Neurons to effectors, somatic is 1 versus autonomic is 2. Peripheral ganglia are unique to autonomic nervous system structure. And in terms of transmitted and receptor types, there are muscarinic receptors and in the sympathetic nervous system, and also noradrenaline is used instead of acetylcholine with the skeletal muscles at the NMJ. In terms of the distribution of nicotinic acetylcholine receptors, they're found both in the skeletal muscle and the NMJ, the neuromuscular junction, and the autonomic ganglia, as well as CNS synapses. There are different types of muscarinic acetylcholine receptors, And what are their different functions? So M1 is present in the stomach and salivary glands and essentially stimulates increased secretions. M2 is present in the heart. It decreases the heart rate by binding and by leading to the binding of an agonist, causing the binding of an agonist causes the inhibition of adenyl cyclase, which reduces CAMP, activates PK following this, leading to the opening and activation of potassium channels in the heart, slowing the heart rate, and ultimately leading to a decreased cardiac output due to the decreased force of contraction, leading to obviously negative inotropic effects. M3 is present in smooth muscle, including the bladder, and it generally stimulates contraction except in the vascular smooth muscle. And agonists of M3 activate phospholipase C, causing the production of IP3 and DAG. IP3 invokes intracellular calcium release, and at the same time, DAG activates protein kinase C, leading to phosphatase inhibition. Both of these actions summate to lead to the contraction of smooth muscles. So in terms of clinical application, we'll just pause for a second and try to write down 3 therapeutic uses of antimuscarinics. So the first clinical application is ipratropium for asthma, which inhibits the contraction of smooth muscle in bronchi. Atropine for the treatment of bradycardia, which inhibits the decreasing of the heart rate. And darifenacin, which inhibits the contraction of smooth muscle in bladder and is used to treat urinary incontinence. So now on to anticholinesterases. So firstly, acetylcholinesterases act on autonomic synapses as they do in the neuromuscular junction, and so therefore, when they're inhibited by anticholinesterases, there will be an effect in both the autonomic synapses as well as at the neuromuscular junction. So it's worth noting that anticholinesterases have differential efficacy depending on the type of synapse that they are acting on. While neostigmine and pyridostigmine tend to affect the neuromuscular junction more than autonomic transmission, the opposite is true for physiostigmine and organophosphates, showing essentially it is worth knowing the distinction between the different anticholinesterases with respect to their effect on autonomic synapses and neuromuscular junction. Anticholinesterases essentially cause the enhancement of acetylcholine activity at parasympathetic postganglionic synapses, increasing the secretions from salivary, lacrimal, bronchial, and gastrointestinal glands, increasing peristaltic activity and via the increased contraction of smooth muscle, pupillary constriction, obviously because it's parasympathetically dominated, and also leading to a fall in intraocular pressure. So it's worth noting that large doses of anticholinesterases can lead to depolarizing blocks. So I'd just like to make the acknowledgement that unless otherwise stated, the diagrams in the PowerPoint were created with BioRender, unless they were taken from a paper where they've been referenced. So all in all, thank you for listening. If you do have any queries, feel free to email me with any questions. Please do also fill in the feedback form in the link with the link provided to receive a copy of the lecture slides and 4 extra MCQs. All in all, best of luck with your exams, and I hope this lecture was helpful.